I'm Michael Lincoff. I'm an interventional cardiologist at the Cleveland Clinic and a clinical trialist.
My name is Jorge Plutzky. I'm a cardiologist. I direct preventive cardiology at the Brigham and Women's Hospital.
So we have two classes that have unequivocally been shown consistently in trials now to reduce cardiovascular events. I mean, that's aside from metformin, which I think, we use or has been used as first line, but has a relatively weak body of evidence based upon subgroup analysis. But so we have the GLP-1 receptor agonists and we have the SGLT2 inhibitors. But the profile of cardiovascular risk reduction with the two has been somewhat different, suggesting that they probably have different targets. Is that your understanding as well, Jorge?
Yes. I think, when we look at the trials with the GLP-1 receptor agonists, that, first breakthrough was with Liraglutide. Of course, all these agents end in that, TIDE, the tide. Any shorthands and tricks for cardiologists to get their head around these is helpful. So Liraglutide in the LEADER study, which was really in response to the need to demonstrate safety, actually showed cardiovascular benefit. And that benefit really lined up with a reduction in cardiovascular events related to atherosclerotic cardiovascular disease, so MI, stroke, cardiovascular death. That evidence was quite clear cut. And then, of course, people looked at that, were, impressed, surprised. It really seemed like a breakthrough, but we like to see it again with other agents. And in fact, well, we did have follow-up trials with semaglutide that also showed benefit, and now we've had several GLP-1 receptor agonists that have shown this improvement in cardiovascular outcomes, allowing for meta-analyses to aggregate that data on cardiovascular outcomes, and it really does line up with the idea of improvement in atherosclerotic complications with ASCVD events.
Yeah,
and that signal has been, quite consistent for the agents that have shown benefit.
and in contrast, the SGLT2 inhibitors, which also are not the focus of this series, but certainly have revolutionized our care in cardiovascular disease, as well as heart failure and even beginning in kidney disease. Those have shown a different profile, right? It's reduction in mortality, but reduction in heart failure, reduction in heart failure hospitalizations, in progression of renal disease or deterioration of renal function. So they seem to be mechanistically different and maybe quite complementary.